Hello, everyone. Welcome to this new IWC webinar, which is part of the online continuous education program of FIRCAD IWC. We are very happy to welcome all of you for this last session of the year, just before the end the holiday season. We are very pleased to welcome all of you. And today we are pleased to welcome our colleagues and friends from Turkey and Belgium. We have Ali Havit and Murad Kabiloglu from IWC Istanbul too. And we have also, and we are very happy, Chul Goorens and Laura Milleneers from IWC TIENEN in Belgium. So I will be moderating this session with my co-chairman, Shihab Taleb from France East. Hi, Shihab. Thank you for being here. And we will have also Lorenzo Merlini, Lucian. They will actively help for the debate, and they will manage also the Q&A session. So we will have two excellent cases today in interactive format as usual. I encourage you to actively participate by answering the polls. We will have some polls during the discussions and to post all your questions. So right now we will start with the first case with IWC TIENEN, Laura Milleneers together with Shulki. I wish you all a great webinar. Welcome to everyone. And Laura, the floor is yours. You can start sharing your case, please.
First of all, thank you for inviting us to this webinar. And I also want to thank Dr. Goorens, of course, who was my mentor for until now, and to who all the credit will go for this presentation. So this is our case. It's about a 62-year-old female with thumb-based pain for now 1 year. There is no history of trauma. She's a manual worker. She doesn't smoke. She has no pain at rest, but with only few activities, the pain goes really up. She had already a STT fusion in another hospital. On her other hand, she's not really happy about that, but she doesn't want to do anything about that hand. She came to us with her other hand. Clinically, she has pain at the STT joint and pain with radial deviation. She has quite a good mobility, and the power grip strength was quite okay. So these are the issues.
Okay, Laura, we will stop you just 2 minutes just to start with this STT pain in a 62 years old patient. You have this imaging. I would ask someone to comment the X-rays, please, and to tell us what else we could ask as imaging exam. Maybe we have Mohammed, who you're just in front of me. I'm sorry.
Yeah, it's okay. I just turned on the mic as well. So we can see two different X-ray here. The left two views, AP and lateral, which pre the procedure shows arthritic changes in the STT joints with maintaining of the carpal bone stability. We can see the other articular surface of the carpal bones, no narrowing, no arthritic changes. And the lateral view, the lunate position looks perfect. There is no other instability can be seen. However, in the other views in the X-ray right side, AP and lateral post the procedure, we can see the four corner fusion that was done for the STT, or some people they consider it as a three corner fusions, and with a broken screw. Yes, yeah,
Perfect.
that's all.
Okay, thank you. Do you ask any other imaging exam for this? Just quickly, Mohammed.
Yes, CT.
The CT? Why do you
Yes.
prefer the CT over any other exam for MRI, for example?
For this case per se, I want to see the articular surface of all over the carpal bone joints to consider another joint fusion as well.
Okay. Okay. Thank you, Mohammed. I see already Shihab has something to say. Shihab.
I have just one question for you, Mohammed. Before just the X-ray, can you just tell us where is the painful zone in your clinical aspect? I mean, do you think the thumb could be painful when you see these pictures, or do you don't pay attention to the thumb? I mean, do you think it's part of the thumb pain, or it's just a wrist question?
No, it's most of this condition they will present with thumb pain. So first things comes to in my mind as a first CMC arthritis. So
Okay.
the thumb
So
could be painful in most cases.
okay, thank you, Mohammed and Kushab. Anyone who would like to tell us if which exam would be the preferred exam? We had the CT scan from Mohammed. Maybe Ricardo, Z. Someone would like. Hi,
Zirine
Z.
here.
Hi, Z. How are you doing?
Hi, I'm good.
Happy to see you.
Yes, happy to see you guys too. So nice. Actually, I would do MRI. Well, I always do MRI anyway. But I'm sure a lot of people actually disagree. Radial sided wrist pain sometimes, like what everyone said, could be a CMCJ, could be STTs. Some may even have an asymptomatic STT arthritis. You can also have a scapholunate. So I think MRI really gives me a better idea as to the ligament status, the cartilage status as well. That the CT can be a little bit limited for that. That's my take on it.
Okay, so for the thank you, the for the MRI to assess the ligaments and to have a better assessment of the cartilage. For Mohammed, the CT. Yes, we have Ricardo.
Hello, Alan.
Hi,
Good morning.
Ricardo. How are you doing?
Hello, everyone. Do you mean CT or MRI now with the
Yes.
plate, or before the first surgery?
No, I think we are talking only on the X-rays on the left side because the right side was already operating. The left side is the case you are talking about.
Okay, I agree with Zé. I think is MRI show us the status of the cartilage of the and the ligaments, the scapholunate ligaments and the cartilage. You see the lunate. It's a little bit indizzy. So I think it's danger to the scapholunate ligament have some kind of lesion, and the wrist have a instability with the STT arthritis.
Okay, thank you, Ricardo. So if you look at our first polls, we see that 54% of people vote for CT scan to assess STT joint and bone anatomy. We have 31% for the MRI to evaluate the cartilage. So we don't have a real consensus. Maybe we can think about having both exams if we have the possibility. And some people vote also for the bone scintigraphy to identify the pain generators. So thank you, everyone. Laura, can you show us what you did and go on with the presentation, please?
Yes. So, voilà. So we went for a bone scintigraphy, also to see the other joints were not affected. And here you can see clearly on the left side, because it's about the left side, that the STT joint is the only affected joint for the moment. So, of course, we tried conservative treatments, but it didn't help. So
we can.
Yeah.
Right now, you already tried the conservative treatment and it didn't help. So right now we will go to the discussion with everyone, which would be the preferred. We will do a roundtable preferred therapeutic option. I see Lorenzo just in front of me. What do you do, Lorenzo? What is your preferred option in Paris?
You mean if we have to go for a surgery now? You mean?
Yes, because conservative is not effective.
So in that kind of situation, isolated STT arthritis with we cannot say it's no ligament problem and really isolated STT problem. Usually I go for arthroscopic STT resection, partial resection. For years, I've been doing, as you know, the distal pole resection and tendon interposition. Now, for the last maybe 2 years or so, I've been trying to resect more the trapezium and trapezoid, as Andrea proposed in the last publication, with no interposition. And so far, I have good results also with this technique. But usually, I go for this kind of technique now. Yeah.
Thank you, Lorenzo. We go on with the roundtable. Carlos, hi, Carlos. Very quickly,
Hello,
Hi,
everybody.
how
Can
are
you
you
hear
doing?
me?
Yes, perfectly.
Good.
Quickly, what is your preferred option here?
There's a very interesting paper from Dr. Axey where he tried this case with arthroscopically, of course, a procedure over the trapezoid cartilage surface. He made a little resection for this case. With this technique, he doesn't make any injury about the ligament system. So I think that it could be a very good option for this case, this patient.
Thank you, Carlos. We can go on. I see Francesca. Hi, Francesca. Are you with us?
Hi, yeah, I'm with you guys. I'm just in the public transport right now, so I have a lot of noise. But I don't have a good solution for STT arthritis. My best results, I have them with trapeziectomy, partial removal of the scaphoid, and mini tie rope.
Mini tie rope, yes, to maintain the height of the joint.
Of the first metacarpal, yeah.
Yes. Thank you, Francesca.
I personally don't have, like, I did it, but I don't have good results with the removal of the distal point of the distal pole of the scaphoid.
Okay, thank you. So many people are for the resection and the arthroscopy. Abdelrahman, we haven't heard you until now. Hi.
Hi.
How are you doing?
I am with you. I'm in surgery at the moment, but I'm trying to listen.
Thank you.
Yes. I think I was discussing with my residents at the moment between the arthrodesis and the distal pole resection and the tightrope. And I think we should also think about what the patient needs. For example, if a patient needs more stability, like heavy worker, we might think of more toward arthrodesis. And if a patient needs more range of motion for a non-labor job, I would go the distal scaphoid resection and the tightrope.
That is thank you, Abdelrahman. It's a very interesting point of view. We need to take in account the status, if it's a young patient, active young patient or not. That's very interesting. Just before going on, Shihab, do you have any opinion on this, please?
I like to try first to put something in between. I mean, you have a great thing with the pyrocarbon. We have a pirocardan. Is a French implant, and I think it makes the good job, because if it doesn't work, you can fuse it at the second time, and it can spare some times, I mean, between the first surgery and the second one. And it's quite not really demanding surgery. If you add an arthroscopic shaving or synovectomy, it's really pain relief and keeps some motion. I'm always afraid about when you fuse this joint that you can have some disturbance regarding the scaphoid and the radius when the scaphoid is stuck on the distal pole. So my first concern would be about this. So first choice would be the interposition with a pyrocarbon.
Thank you, Shihab. So if for me, just to conclude, for me, I would do arthroscopic resection and as Shihab, interposition for the moment, but it's more and more pyrocarbon implant, but it's more and more difficult to have the implants. So there is a tendency to go for the Adzei technique with a more important resection. If we have a look at the poles, we have 21% for conservative treatments. Go on with the conservative treatments, even if it didn't work in the first place. We have about 21% of people for arthroscopic STT fusion and STT resection arthroplasty, 14%. So there is a discussion on this. So we will see what happened after.
We have a question, Alam, from
yes.
Yeah.
Thank you.
So it's our friend Peter Bastian from Belgium who is asking, if the pre-op range of motion and hyperlaxity influence your decision making in this type of surgery.
Maybe we will ask the question to Shulki because he did the case. Where are you, Shulki?
Of course.
Yes.
The characteristics of the patient is of course important. What to choose to maintain the mobility or not. So yeah, of course, it's quite important. See also the hyperlaxity or not. Yeah.
So how do you can you explain to our young colleagues how does the hyperlaxity modify your choice for the treatment?
If the patient is hyperlax, we will be more reluctant to do surgery. We will try to keep the patient off surgery. Then, if it's mostly like a 60-year patient with STT arthritis, then you are less reluctant to do the surgery.
Okay, thank you. Do we have any other comments on this? Ali, for example, Ali Habit. We lost him for the moment. No problem. I think we can go on with the case, Laura.
Yes. So it takes a little time.
No problem. Take your time.
I don't know why it's not good.
Yes.
Perfect. So I think all the options we're talking about. So of course we can do arthrodesis of your STT joints or resection arthroplasty. You can do it open arthroscopically, but it's an arthroscopic talk today. So you can go for pyrocarbon interposition, but as you said, it's more and more difficult to get them. Trapezectomy is also an option. Of course, you are scared about subsidence of your metacarpal. And if you want to be really aggressive, but that's maybe in a later stadium, you can go for scaphoidectomy with four corner fusion or proximal row. For this patient, we choose to do an STT fusion. In Belgium, it's quite popular to do STT fusions for pure STT osteoarthritis. The common thing is to do it in the open way, but we were asking ourselves if it was also possible to do it on the arthroscopic way. And so that's what Dr. Goorens did in Tienen, and Dr. Van Mierlo did it also in Roeselare. So what do you need if you want to do it arthroscopically? The same instruments as you always use for your arthroscopy. But you will need, of course, a burr to take out all the cartilage of your STT joint. You will need a bone biopsy device to take bone grafts. We take bone grafts from the distal radius and then we put them in the STT joint. And you will need some screws to fix your STT joint afterwards, and fluoroscopy because you want to see the placement of your screws. So how did we do it? Basically, we use the standard portals, so the two midcarpal one, the MCU and MCR. You don't need special portals to do this surgery. And the interesting thing is that your scope has to be in the MCU, so you have to get to the STT joint from the MCU portal. As you can see in this video, you have to go upwards through the scaphoid and then turn your cable to see the STT joint. But once you're there, you have quite a nice view of the STT joint, and it allows you to have your MCR portal to put in the shaver and to shave the cartilage. So that's the next step. You need to resect all the cartilage in the STT joint. Here you can see the shaver that's going through the STT joint. And that's when it's done. When you see this cartilage here between trapezium and trapezoid, you're quite happy. You know you resect the STT well. If you're not sure, you can release tourniquet, and then you will see the bone that starts bleeding, and then you're really sure. Once you have resect everything, of course, we have to put the bone grafts. So here you see also that it was bleeding. So we were happy and we started the bone graft. So this is the Trefina that we used. You can also use a Yamshili needle if you have that in your hospital. It's quite the same. It's a little bit smaller, but the two are possible. And then you can see here in this video the bone grafts that are put inside, voila, the STT joint, and then you have to compact them with some moral fascio or something else. And you do this a few times until you're happy and all the STT joint is full with bone grafts. Once you're happy, you can stop the arthroscopy, but then you have to fix your construction. So we do fixation with screws. We do it only in a percutaneous way. As you can see here on the slide, the screw that we put through trapezium and scaphoid, we do it the same way as you do fixation of a scaphoid fracture through the trapezium. But of course, we leave the screw partly in trapezium and partly in scaphoids. It's also Accutrack Mini, so the same you will use for a scaphoid fracture. To put the screw through the trapezoid and the scaphoid, we go from dorsal between metacarpal 2 and 3. You have to put the pin first through the base of the second metacarpal, and then you go through CMC2 to get in the scaphoideo-trapezoid joints. And the second screw is Accutrack Micro and not Mini, because it will be too big, I think, to put two Accutrack Minis. And this was the lady we just talked about. It's an X-ray at 6 weeks. Postoperatively, we put 2 weeks of below elbow thumb cast, then a removable splint until week 6, and at week 6 they start automobilization. And at 12 weeks, we do a CT scan to be perfectly sure it's healed. And here you can see the CT scan of this lady. It's completely fused STT joints. Clinically, the patient was also very happy. This is the same lady at 3 months post-op. She has no pain anymore. She has a good range of motion and a good power grip strength. Why should we do it arthroscopically and not in an open way as we always did before? As we all know, open STT fusion had a quite non-linear rate, around 20%. I think that's the reason a lot of surgeons don't do that. And we believe arthroscopically, because it's less invasive, we will preserve more vascularity. We will have a higher union rate. We can see it already with the non-union treatment of the scaphoid. The union rate is quite higher arthroscopically than it is in the open techniques. So as I said, arthroscopically is minimal invasive, will preserve vascularity. You need to resect less bone than open to have your fusion. And it preserves the ligaments. I think also a very important point. I heard before some of you will ask for MRI because they want to see ligaments, they want to see the other articulation. If you do it arthroscopically, you can see all this before you really start the surgery. This you can adapt if there is something you didn't see on the imaging before. Of course, there are also negative points. You need a lot of instrumentation, more than open. I mean, it's a high learning curve. And maybe the most negative point is that you don't have a view on your reduction. It's only indirect reduction of the scaphoid. When should we do an arthroscopic fusion? Of course, for primary osteoarthritis of the STT joints. Maybe in the early stage of psoas wrists, but when you already have arthritis between lunatum and capitatum, I think it's too late to do STT fusion. And Eaton stage 4 thumb arthritis, as we will see later on a case, you can maybe combine STT fusion with something more. There are also alternatives. You can do an open fusion, but we are scared about the non-union rates. You can go for a resection arthroplasty, but there are some literature about carpal instability afterwards. And of course, you have this solution to resect trapezium and trapezoid instead of scaphoid, which will also be a good option. And you can go for interposition arthroplasty, where you put a pyrocarbon, but there are also some cases, as you can see here, where the pyrocarbon dislocates. This is a study that Dr. Goorens and Dr. Van Mierlo did. So it's about 11 patients who get STT fusion arthroscopically. They already presented at the FESH and they will present it at GEM this year. As you can see, for these 11 patients, they had quite good results. The pain was nearly gone. They had really good range of motion and really good grip power. If you compare with the other side, it's the same study, but it's compared with the other side, you see that the grip strength is 30% less than the other side and range of motion also, which is not that bad, I think. But the most important is this, it's 100% of fusion rate. And currently they have 25 patients instead of 11, and they still have 100% of fusion rates. There was one other study in the literature who already did STT fusion arthroscopically, only with 5 patients, and they had 80% of union rate. The difference were, first of all, they use iliac grafts, and we believe the distal radius will have a core decompression effect, as we see with Kienbock disease, which will enhance vascularity and bone healing. Second important point, they use 4 portals, so they also make some volar portal. And I think the most positive thing of arthroscopy is that you will preserve vascularity and be minimal invasive. If you do 4 portals around an STT joint, maybe you will also devascularize the joint. And third point, they use screws for some patients, but they also use pins for other patients. So maybe this will also play a role in their results. But of course, they also have not that bad results. And this is also an interesting case. It's an STT fusion that was done in AZ Delta, also in Belgium, but the patient developed painful CMC1 arthritis afterwards. That's
sorry, Laura. I will just stop you just at this time. You have this case with CMC1 arthritis later. And I will ask everyone, what would you do? We see here there is a CMC prosthesis. I will do a round table. We will start with Lorenzo because he would like to speak. We don't hear you.
I raised my hand because there was a question in the Q&A. That's why. But
okay, but we will answer maybe the question after. What would you do, Lorenzo, in this if the patient develops CMC arthritis after STT fusion?
After STT fusion, well, I don't do much STT fusion, so I don't know. But usually, I tend to do a CMC prosthesis.
After, okay.
Yes.
Okay. We see maybe Z, if you are with us, or what would you do here after STT fusion if you have CMC pain, CMC1 pain?
Well, in my mind, it's quite relatively straightforward. You either keep the trapezium or remove the trapezium. But if you already fuse the STT, it's very difficult to remove the trapezium. So I will make sure that there is adequate space for arthroplasty.
Okay. Yeah, that is very important, the adequate space. Ali, do you have an idea on this?
Yes, Alam. Hello, everyone. Actually, we don't have arthroplasty for CMC joint in Turkey, so we have to do something else. So,
and what would you do?
Yes, we even we don't have a trapezium because it's already fused, but we can remove the screw and remove some part of the trapezium. And actually, I like doing tightrope stir button in CMC cases. It works well in my hands, and I like the outcomes of it.
Thank you, Ali. Ricardo, Joyce.
Yes, I'm agree. I think arthroscopically you can remove the screw and resect the distal part of the trapezium and maybe do some kind of ligament reconstruction with a tie hope.
Okay, thank you, Ricardo. Laura, can you show us the end of your case, please?
Yeah, so I think everyone already saw it, but we take out the screw effectively, and then we put a CMC1 prosthesis inside. Maybe it will be a good option to preserve the trapezium in the future and avoid trapezectomy, which we know can lead to metacarpal subsidence. But actually, we don't have the answer, of course. So I think this was the end of the presentation.
Thank you.
If there are questions, of course, we will be happy to answer them. And to conclude, I just wanted to say that STT arthritis fusion is an option for STT arthritis. It's not the only option, of course, and that it's feasible arthroscopically. So maybe it will be something you will use in the future. I hope so, but of course, for very specific patients. Thank you very much.
Thank you, Laura. Very nice case. Very, very nice. Could you please just stop sharing your screen for the final discussion, please?
Yes.
Thank you. Perfect. Lorenzo, we can start with the chat. Maybe we have some questions.
Yes. Thank you, Laura. Very interesting and nice case. So the last slide was actually good for the next question that was asked into the Q&A section. So the question was, does STT fusion has an increased risk of later on CMC arthritis? You show in your case it was the case for this patient, but do you think that fusing the STT can change the biomechanics of the thumb column to increase the risk of CMC arthritis?
Actually, in all other patients, we don't have CMC1 arthritis. So maybe this patient was a missed CMC1 arthritis from the beginning. But we don't know, of course. But in the 25 other patients, there was no effect on the CMC1.
Okay. Okay, great. And the other question that was asked is that, did you have any data on comparing the thumb range of motion and strength of the thumb between STT fusion versus STT resection, for instance? Do you have anything? Do you have any idea on any difference on this topic?
Maybe we can ask Chulki, maybe Chulki, because he's saying yes or not.
No, no, we didn't compare it. No, it's really our habit to do the fusion over the resection arthroplasty in Belgium, I think. And it's just this shows us that we try to do it arthroscopically. What we used to do it open. So it's not that we have a good experience in resection arthroplasty.
Even if even in other patients, elderly, woman, non-labor.
I did it a few times in elderly patients. Of course, it worked well. In younger patients, I was more reluctant to do it, and I preferred to follow my old habit to do the fusion. So that's my rationale.
Okay, thank you. I would like just before going on with the discussion and the final discussion. We have 69% of people after the pain on the CMC joint after STT fusion who would do trapeziectomy for the treatment, for the associated treatments. We don't have a lot of arthroplasty. I would like to finish just with a short roundtable about this case. Your final point of view, Mohammed. What do you think about the case? Very shortly, what would you do differently?
It's a nice case. Thank you for you, Laura and Shulki. Actually, from the beginning, I want to consider: is it first CMC arthritis or is it STT arthritis? I need to confirm this point from the beginning because some patients, they mostly complain of first CMC arthritis rather than the STT arthritis. And this is the only thing that I want to consider it again.
Thank you. I think Shulki would like to answer.
That's why we always do the SPECT CT scan, in fact, to exclude the CMC1. Mostly we do both. In fact, we do MRI scan and the SPECT CT scan. And in the SPECT CT scan, we have also the evaluation of the CT, of course.
Interesting. Thank you, Chulki, because I'm not sure everyone do the SPECT CT scan. So that would be interesting to. Do you do sometimes, Chulki, injection under ultrasound, for example, to make sure the pain is coming from the STT joint?
Yeah, our preferred first treatment is mostly an injection. So we do mostly the first injection. And if it helps, then we keep it conservatively, of course.
Thank you, Chulki. I see Shihab has a question, comment.
Maybe we have a cheaper way to assess if it's coming from the upper side of the level under. I mean, if you go to the clinical aspect, if you have a patient who is painful when you have a flexion of the wrist, it means that sometimes it comes from the STT. If he's painful from moving his thumb, I think it's painful from the CMC. And most of the time when we do arthroplasty, my goal is to be sure that STT is not painful. Otherwise, you go to the wrong way. Of course, you can add other fancy stuff, but the most clinical important aspect for me is to each time to assess if the flexion of the wrist is painful or not, and if the thumb is painful or not.
Thank you, Shihab. Merci. Clinical assessments is all the time very important. Ricardo, do you have any comment? Would you do something different from this case? It's a very nice case with the fusion.
Yes, it's a very nice case. You have very good solutions. But I don't do fusion for STT. I prefer some kind of treatment that you keep moving the joint. So I think it's everything is said in the presentation. You must see first if you have some kind of ligament lesion associated with the STT. So I do arthroscopic view of all joints before do the treatment of the STT, and I prefer doing the resection of distal pole of the scaphoid or the Copernical surgery doing by ATSE. And after that, do some kind of ligament reconstruction of some kind of stabilization of the joint.
Yes, thank you, Ricardo. You worked a lot on this topic. Thank you. So you have yes,
I love this topic.
Yes, I know you have the good point of view. So we see there is no real consensus. Many options are possible and feasible. That's why it's very interesting to have this case. Thank you, Chulki and Laura. I think we have a question maybe in the chat, Lorenzo, no?
Yes. The question was, I guess it was a simple answer, but the question was, what were the causes of STT arthritis in your series? But I'm guessing it's primary STT arthritis in most of the cases.
Yes, even the simple question needs an answer. So thank you. Someone else would like to, thank you, Lorenzo. Someone else would like to add a comment to close this roundtable. I feel Zerin or Ali, they really want to say something. We have Abdelrahman. He wants to say something. Abdelrahman, please.
Yes, I was wondering, why don't we use the radial to ulnar deviation and dart thrower motion, range of motion, as a measure of this rather than flexion and extension? Considering, especially when you are fusing the STT joint, wouldn't dart thrower motion or radial to ulnar deviation be more effective than flexion extension?
Chulki?
Yeah, it's correct. It will be more effective. It's something to discuss with the patient before surgery. In fact, most of them are already a little bit stiff before surgery. So we saw that patient didn't increase much stiffness after surgery, but especially on lateral motion, no, we didn't check it. It's a good suggestion.
I think we should use it. I think we should be using it when we are comparing both treatment options or outcomes. It's more, I think, specific toward STT fusion versus resection rather than just complete total wrist flexion and extension.
Thank you, Abdelrahman. I see, Carlos, you have one of the last comments because we need to go on with the next case. Carlos.
Yes, it's not a comment, it's a question for Ricardo and from everyone. In this case, with the patient 82 years old. What is the concern about the mobility of this STT joint? It's about the repercussion on the rest of the corpus, or it's something else? I mean, in order not to use this technique, this fusion.
I think you're right, Carlos. You have make some kind of treatment for each patient. For older patients, I think fusion is a very good solution because you don't have overload the other joints like the CMC or scapholunate joints. So you don't have to pay attention of this kind of overload of the other joints. So I think it's a very good solution, a very nice solution. And even with arthroscopy now, you have a higher rates of consolidation. So in the past, you have using plates and screws, and you have a higher rates of non-union. And now with the arthroscopy, you have 100% of bone union. So it's a very good solution for this case, and I'm very happy with this kind of treatment.
Thank you. I think we will need to close very shortly this first case. Just Chul, I would like just to ask you if you have some advice for those who don't do very often the STT fusion. Do you have some key points in the surgical technique for the graft? Is the graft necessary, and some advice to avoid technical problem maybe you had in the beginning, in the first place, when you were doing the first cases?
Yeah, it's I think it's most important that you don't use too many portals and keep the portal rate low, and therefore you should stick with the MCU portal to access the STT joint. And it's it's a little maneuver trick that I learned from Andrea Zey doing the round block technique. But it's not so difficult, but you have to get used to do this technique. And the other thing concerning the grafts, you need to pack it very much. So you need a good bone biopsy device and really stuff it if you want to maintain some kind of height.
The graft is for the height, yes. It's not possible to avoid the graft just like we do with the partial mid-carpal fusion, for example.
For the mid-carpal, I don't think it's so necessary to put grafts, but here it's more important,
Okay, so thank you, Chul. Thank you, Laura. It was a very nice case. You have seen it's one of the possible treatment for STT arthritis. It's not consensual, but it's very interesting. It can be reproducible with some selected patients, and we need a precise technique, as Chul has told us. Now we need to anticipate some other pathologies, secondary pathologies like CMC1 arthritis. So thank you for sharing your experience, and I will give the floor now to Shihab for the second case. He will moderate the second case. Thank you.
The second one comes directly from Turkey, and we will talk about another level, which is the mid-carpal one. And if we can share, Murad, that's good, your case, and we will split it in diagnosis, treatment, and after discussion. So the floor is for you.
Thank you. Can everybody hear me?
Yeah, we can.
I will just start right about now. This is a 25-year-old patient I'm presenting. He's a taxi driver. On 2017, when he was carrying a glassware for a window, a very heavy glassware, it fell onto his hand and the glass shredded, but he didn't have any fractures, but he had lacerations, and it was operated on in a private clinic in 2017. He was followed in a short arm splint for 3 months, and then he went to physical therapy for 1 year. In 2023, intra-articular injection was done to his wrist, and he came to us with a left wrist pain, occasional swelling, limited range of motion, pain at rest, and exacerbated by activity. His flexion on the non-affected dominant right side was 80 degrees. On the affected side, 20 degrees. Extension right 65 degrees, left 30 degrees. So radial deviation 30 degrees on the unaffected side, 10 degrees on the affected side. Ulnar deviation, really wide difference in ulnar deviation. Right 40 degrees, left 5 degrees. And grip strength, again, a wide difference. Right 110 pounds, approximately 45 kilograms, to left 45 pounds, 20 kilograms. His VAS score is 9 out of 10. Quick Test score is 74. PWE pain score is 41. And on the function scores, the specific activity score is 54. And usual activity score is 31. These are the preoperative x-rays, AP, lateral, and navicular. So I'll stop right here.
So now we found some volunteer. I guess they will come from Belgium. Do you think, Laura, you have some idea regarding the X-ray? I mean, what do you see, and what would be your diagnosis, and what would you go for another exam or treat them directly? Can you tell us what would be your favor for this?
So we see some arthritis between capitatum and lunatum. Not a lot. I think.
So just to help you, it's not a STT arthritis from Chul. It's another case.
No, I think STT is maybe a little bit affected, but the most of the problem is between lunate and capitate. To this X-ray, when you see the profile, I think the lunate is not too much in dizzy or visi. It's well aligned, and scaphoid is also still aligned.
Okay, what would be the next step for you?
I think I'll do an MRI to see all the other articulation and ligaments in around the wrist.
Okay, and what happened around the Bosphorus, Murat? What did you do?
What did we do? I will just continue. We went to and done an CT scan.
Sorry, I just would like to stop you 1 second, because for our polls, we see that most of people, they answer for the MRI to evaluate the cartilage and maybe to exclude Kimbog disease, beginning an atypical Kimbog disease. We have 24% for the CT scan. So the majority of people would ask for an MRI. Thank you.
All right.
And you did a CT scan?
Yeah, we did both CT and MRI.
Okay.
Because
this is the coronal CT. This one is the sagittal. Coronal MRI. And sagittal MRI. Any treatment options from the faculty?
so who?
I want to ask a question.
Yes, Abdulrahman.
What is there a DC deformity that I see, or do you think the scapholunate is injured or something?
In the arthroscopy, we didn't find that.
But on the MRI, you see the lunate is the.
Can you show us? Go back, please, Murat.
Sagittal MRI or
yeah,
sagittal, yeah. You see the lunate, I think.
So what is your point of view, Abdulrahman?
I'm looking for the cause for why would you have isolated capitolunate arthritis, and I see the lunate is tilted dorsally a bit. Maybe it's the position of the patient. I'm not sure, but wouldn't you consider an scapholunate ligament injury possibility or instability at least.
We have the
as a
MRI and
cause.
the CT. We have the MRI and the CT scan. What would you do here?
Scopy, of course, the gold standard.
And Francesca, you raising your hand. What you have question, comment regarding the?
No, I'm just saying that like you can like Mia would probably do a fusion between the capitate and the lunate, and you can do it arthroscopically. You just use the typical portals, and I think the presence of knot or of a scapholunate instability, since you do an arthroscopy, it's not a big problem. I mean, even if there is a lesion of the scapholunate ligament, you can always repair it. You can do an ADCLR, a dorsal capsulodesis if needed, but probably the lunate is in dizzy because of the arthritis with the capitate.
Okay.
Okay, and what about you, Zay? Do you think you have the same concern that Francesca and Abdurrahman regarding the ligament, or do you think we already passed the step of treating the ligament?
I think it's a bit too late. The arthritis seems quite advanced. And I personally have this kind of case before with isolated lunocapitate. And when I put in the scope, I found that the capitate head cartilage was coming off, is a little bit soft. So I actually sort of resected a little bit of the cartilage of the capitate head and also placed in the tendon interposition through the mid-carpal portals, dorsal and volar. And that patient did not really have a good outcome. I think the post-operatively, you can see the lunocapitate gap is there. You're all happy. And then over time, the gap slowly closes down and then the patient still has some pain. So I didn't really have a good outcome from that, but that's only based on one patient. I think this is quite rare. So I think moving forward, I might probably consider just doing more radical four-corner fusion, arthroscopically kind of situation with scaphoidectomy. I think that's more predictable, either a PRC with interposition of some sort.
Thank you.
Lorenzo,
Yes, just before, I would like to tell you that I shared the pause after we go to Lorenzo. We would like all to understand a little the etiology about this isolated lunocapitate arthritis, because it's not so frequent. So maybe, Shihab, we can make a roundtable about the possible etiology, started with Lorenzo.
Well, thank you for this horrible question. But yeah, I've encountered several cases of these, and I think it's important to understand the etiology nonetheless, even if it's not so frequent and not so easy to understand, because in some cases it's really an isolated mid-carpal arthritis, and we don't know exactly it's a primary arthritis, like which one you can have in the whole body. I had several young patients with this case of arthritis, but it was actually an equivalent of a vascular necrosis of the head of the capitate, really partial, but it's actually an existing and described pathology of the wrist. You have a partial avascular necrosis of the head of the capitate of the subchondral bone. It doesn't have to be big, but if it's only partial but really proximal, you can destroy the cartilage of the head of the capitate, and then it leads to lunocapitate arthritis. And this is actually the most frequent cause of this rare pathology that I've met, that I treat now. When I see it, we published a paper on this technique. We do a tendon hammock interposition between the lunate and the capitate, do a partial resection of the capitate to debride it, and that's it. Yeah, it's not perfect. It's not a perfect situation and not a perfect surgery, but it's nonetheless what I found the best to be a good compromise between not doing too much aggressive and not doing nothing either. So that's it. Yeah.
So thank you. We understand that the etiology is very important, because if there is a ligamentous, if it is an isolated lunocapitate arthritis, maybe the interposition would be a good choice. But if there is another etiology with the interposition, we don't treat the etiology.
Yeah, you have to treat the cause otherwise. Yeah.
The cause. So Shihab, I let you.
Yeah. Murat, what have you done after the next step?
We did arthroscopic fusion surgery afterwards. Yeah, we went in from the mid-carpal ulnar portal, and as you see, the patient has a lot of synovitis and fibrous tissues. We open the radial portal right now, and we will debride it to make our viewing better. After debridement, we went in with a burr, no shaver, and we are debriding it. This is a long video, so I will just skip ahead. Yeah, continue debridement of the lunate. You can see the arthritis. And now we will go in with a burr to debride the arthritic surfaces, partial debridement of it. Lunate facet is being cleared. Now we are clearing the capitate. And you clean it until you see the subchondral bone and little signs of bleeding, so you know that you are down to the alive bone. All right. And in this next part, we took the bone graft from the iliac crest with Cemshiri biopsy needle because we don't have the apparatus Miss Laura mentioned. And we are inserting it arthroscopically using a mini periosteal elevator. We will put it into the defected area until it fills up and we see that it is completely fulfilled. Pardon me. Yeah, the debrided area is filled and then the traction is released and we go into the fluoroscopy. These are the grafts. This is the debrided area. And now we will do percutaneous pinning. We are passing the guide wire from the capitate to lunate. And this is the end result of the surgery. A headless compression screw is used to fuse the joint. Then we will go on to the post-operative follow-up. I think I will stop here.
Yeah, great case. Isn't anyone in the panel have other techniques for the fusion? I mean, do all of you use cannulated screws, or you want pins, or you only put bones in between the two other bones and let it heal by itself with a cast. What is your feeling? Shulki, what do you think about this technique?
I like personally the screws. I personally have a better night rest when it's well fixed, and I prefer only one surgery, not to remove a second surgery for the removal of the pins. But I do know that many have good experience with only pinning, so it's just my personal way that I do the screws. Yeah.
Alan, do you think that we should, in all those cases, harvest grafts, or because it's arthritis and it leads to fusion by itself, just speed up the process by removing some bone and putting on screws, because it will get a most faster procedure? I mean, when you need to fuse, most of the time, just let the bone do what he is supposed to do.
That was my my comment and my question for Ali and Murat. I had some cases of lunocapitate, isolated lunocapitate. Just to answer the question we had before, there are some in elderly people. There are some inflammatory etiology. And also, it's very rare, but we have some inflammatory etiology, and it's quite obvious when we have the X-rays to have this inflammatory. So I go for the lunocapitate fusion all the time. I don't do interposition. I'm really afraid of the long-term outcome. So for the partial fusion itself, we know that the most important thing for arthroscopic partial fusion, the main concern is the surgery time. Because in the first arthroscopic partial fusion, the surgery times that were published were 3 hours, 3.5 hours. It's the main concern. So we need to save time. Whatever we do, we need to try to save time. The first thing, sorry, when we need to do scaphoidectomy would be to do, for example, mini open scaphoidectomy instead of an arthroscopic scaphoidectomy. In this case, I would say if we do a very economic resection and if we preserve the curvature of the carpal bones, maybe it's not really necessary and mandatory. But I feel, Ali, if you choose to do the graft here, that's because you had really a loss of bones, or what is your position? Because I think it's not mandatory if we go only to the subchondral bone with a resection, and we conserve the curvature of the bone after we have a good shape. Just we put the screws in compression and it's enough for me.
I agree to that, Alam. Thank you for your comment. But for me, actually, I feel more comfortable when I put bone graft to be fused in the future. And also, specifically in this case, after removing the subchondral bone with burr, I have to remove more to reach to the healthy bony tissue. So I have to make a little bit resection. So that's why I took bone graft. Even that I said I feel more comfortable with bone graft. And actually, I prefer iliac crest bone graft rather than distal radius or olecranon, because and some studies also show that it's more it has more osteoblastic and osteoinductive capacity, and I think also the same. So mostly I took from the iliac crest. Also, it's in closed manner with Jamshidi, so it's not so difficult. It's so easy, and especially in such cases when you need lots of grafts, you can get lots of grafts from the iliac crest as much as you want.
Thank you, Ali.
And of course, sorry to add more, if you start arthroscopy, wrist arthroscopy newly, if you are trying it, it can be a little hard to do all the these things together in the same time. It can take time, and you can do just resection arthroscopically if you are a beginner, and after that you can do an mini open and graft and put screws. Yes, it can be a choice also, but I love doing this all arthroscopic because if you don't open, you don't disturb the vascularity, you don't disturb the ligaments. You have less postoperative pain, so I want to do as much as arthroscopically these cases.
I totally agree. Patients are doing much better after arthroscopic partial fusion.
Yeah.
So, just we keep in mind that when we are beginner, when we start the arthroscopic partial fusion, we need to think about every step of the surgery and save time all the time. I think Dee has something to say.
Yes, I have actually a question for Ali. I was wondering, when do you consider keeping the scaphoid during mid-carpal fusion? Would it be because like you think the scapholunate ligament is intact? Hence, I mean, I want to ask, is it okay to keep the scaphoid during mid-carpal fusion? And do we have to check the scapholunate stability first before we consider, okay, let's just do a lunocapitate fusion without a scaphoidectomy?
Yes, actually, in this case, I made my plan when I look arthroscopically. I checked first the radiocarpal joint, check all the ligaments, check all the radiocarpal joint, and I moved to the midcarpal joint and check both the midcarpal joint chondral condition. The tracheotomy is good, as you see in the videos, and scaphoid, there is a mild degeneration in the midcarpal joint, midcarpal chondral surface of the scaphoid, but actually it seems good to me, so I didn't think about resecting scaphoid and keeping it. It can work, I think. So I just do fusion to the capitate and lunate.
So we see there is Francesca also that has a question.
Yeah, first of all, I want to say congrats to the team because it was a great case. And then second, just a technical question, because we saw that the lunate was a bit indizzy. So I wonder if you actually had considered doing the Lisham maneuver to reduce the DC before, removing all the cartilage and doing the fusion. If you would think it would be maybe helpful to put the lunate in a better position and maybe gain more mobility post-op.
Actually, yes, in the preoperative X-rays and CT scans, there is a mild extension of the lunate, but I don't think so. It's too much in extension. It's like a mild, not important extension. So I didn't do anything like Lynchett maneuver, just remove the traction and do the fusion. And after the postoperative follow-up, we can see the extension of the patient is very good. And it's very important for me because he is a taxi driver and he is all the way using car, using the rollers. So the extension is very important for this patient. And so we gain it after the operation. I'm happy about that.
Yes, yeah. I think just for a comment, we can try to reduce the DZ. That would be interesting with the Lynchline maneuver. But there is something very important, Ali. I don't know, and the others, if you agree, we should not try to reduce the lunate on the capitate. We really need to let the lunate in the radio-ulnar plan. We need to let the lunate in the natural position. Otherwise, there will be overpressure on the other joints, and we can have secondary problems.
Yes,
Just you put your screws, you let the lunate in the good orientation, and just you put the screws. Do you agree, Ali?
Yes, totally agree. Because try to put in the same line, it's not the normal kinematic of the wrist. So you can disturb the load distribution, and this can cause in the future time some kind of other arthritis in the other joints.
Yes, it can be one of the mistakes. Shihab, I'm sorry. I need to show the polls results. We have 13% of people, 2 people, who voted for proximal row carpectomy here. would someone here go for proximal row capectomy? Chulki, do you think? What do you think about this? No.
No,
No.
It would not be my first choice. No.
Okay.
It was a misclick.
Maybe.
Yeah.
It can be discussed in the elderly patient, I think, but okay. Thank you, Ali and Murad, for this very nice case. And thank you, Shihab. Do we have any other questions or comments here? Okay, so Abdurrahman has a last comment. Abdurrahman, please.
Yes, I think if anybody is going to go for a PRC, they should consider a capsule interposition at the same time because of the capitate arthritis. Just if this is your choice. I'm not saying it should be the choice, but if you are doing it, do a dorsal capsule and put an interposition.
It's very important, yes, because of ahead of the capitate arthritis. So thank you for this very nice cases from Istanbul, TIENEN. Thank you everyone for attending this last webinar of the year. Thank you, Shihab, all the faculty. I wish you all a beautiful holiday season, and we will see you in 2026 for the just in the beginning of January for the next webinar, which will be with the Mayo Clinic and with Rome, with Sanj Kakar and Lucian Marcovici. So please stay tuned on all the social media. We will give you all the links to register. And I wish you all a very nice weekend. Thank you once again. Bye-bye. Thank you.
Thank you.
Bye, everybody.
Bye-bye.
Bye.